So it's a real pleasure for me to present the results of our scan, environmental scan, to describe the current care received by frail seniors in Canada. So this is ongoing, so we're hoping to complete the study this December. So it's a year project, so so you will see probably the urgent need for these data, and so it's made a lot of decisions because it's a year project. So I thought this one here.
Oh, let's see which one. Oh, not that one.
Oh, thanks. Thank you. Yeah. So the purpose of the scan is to systematically examine the care of frail seniors across the spectrum of care setting in 5 Canadian provinces. The research questions are, what are the health care services and models of care currently offered in Canada for frail seniors? How are healthcare resources used? And what are the major outcomes of care? So we integrate 3 different data sources. First, we're doing a scoping literature review. Then we're doing a data pool from administrative data, and we're conducting also interviews with stakeholders. So in the interviews, we're asking people, stakeholders, what is really important to them in order to shed light on the most important aspects of our work. So this is the way we're integrating the results from all the 3 data sources. So the team comprises people from 5 provinces, researchers, data holders, students. We have also decision makers. And you see the students are in blue here. So the scan covers all the provinces in the review. However, we're doing a new data extraction only in 5 provinces. These, you have Quebec, BC, Alberta, and Ontario, which are the provinces where you have most seniors. 5 out of 6 seniors in Canada are from these provinces. And in the Atlantic City, that's where you have the highest proportion of seniors. So this explains how we build this study. So I'm going to present the challenges we had in identifying frail seniors in all the 3 data sources first, and then the clinical quality indicators of frail senior care in each of the data sources. So first, yes, we did have some challenges in identifying seniors. So first in the review. So we had a lot of iterations with the information scientists to actually select keywords to find the reports. And because if you use all the diseases, it leads to an enormous database of report. So we decided to focus on a very specific search strategy. And I would like to share it with anyone. If you're interested, if you would like to have this search strategy, it'd be my pleasure. It was so much work. So we did iterations also with geriatricians to make sure that it was really relevant and a good search. So once we had the reports, we had to screen them. So here are the criteria. So first, they needed to be about frail seniors, their caregiver, or their healthcare providers. The report should have reported clinical quality indicators. The study needed to be performed in Canada. The reports needed to be written in French and in English, and published after 2009. So you see here an aspect of doing work that's quick. So we only have the reports that were published after 2009. So we call this like current research, right? It's a bit, so a lot of things we're not seeing that are older. So even if a report didn't mention the word frail, you can imagine that some people don't label their participants as frail, but they still include frail seniors. So we did use these criteria to screen the reports. So we, of course, included people who describe the reports that describe the participant as frail. But we also used clinical indices to screen reports. So actual indices that are used with patients, we use them on the description of the participants included in the reports. So we use 2 for this. So the clinical frailty scale developed by Dr. Rockwood, who is here, I think, today, and the Edmonton Frail Scale, because these two scales were really complementary to one another. We also included people who were living in long-term care facilities, so report about participants who were living in long-term care facilities, and reports about people that were at the end of life. So what criteria were actually used? So we included 93 reports. Of those, there were 75 that were really targeting frail seniors, not care provider or caregivers. So of these 75, you see that 83% we were able to identify using the indices. Only 38% of those reports used the word frail, meaning that if we hadn't expanded a bit the way we were looking at the reports, we would have missed a lot. So we're going to look at our challenges now identifying seniors in the administrative databases. So just a small reminder, a lot of you may know, but others may not. So the provincial administrative data, it's health-related data collected and stored in administrative and clinical databases. So it's a cost-effective way to gather data. However, it's indirect. So the data was collected not for research purposes, it was collected to urgently for billing purposes. So we had to develop a new identification rule. We found two different strategies published, but they were really not applicable in the context of the scan because they were missing a lot of people, and a lot of provinces didn't really have the codes that were proposed in these. So I'm just skipping over this. I'm not presenting you the two strategies that we found in the literature, but this led us to develop new identification rules. So this was done based, again, on the clinical indices that I presented earlier, on expert opinion, on literature where some form of claim-based data was used, and on markers from population-based work that may be translated into service utilization by frail seniors, because this was done a lot by many people in our team, that, especially in Nova Scotia with Robin here and Grace, who have a lot of experience with the administrative data. So the new identification rule was based only on claims, which makes it easy to use, right? So we consulted also with team members to ensure specificity. So we focused on a specific rule, and even if it was at the risk of missing some people. But we wanted to consult the team also, who are we going to miss with this? So I think we have a good picture now of what we're getting. So the rule number one is, so we have codes to identify people who are living in long-term care facilities. We have codes also for people who are terminally ill. And then for the rule number three, the people to be included in the cohort need to have at least two of these in the list. So either cognitive impairment, general health status, incontinence, fall, nutritional status. And we also added targeted services utilization, geriatrician billings, provider home visits, and provider visit to hospice. Just to give you a taste, so this is the description of the frail senior cohort in Nova Scotia. This is the only one that's been really completed yet at the moment. So we just got data from Quebec like a few days ago. So you see here, we had in the database 10,000 people. With each of the rules, identification rules, we were able to gather some proportion of frail senior. In the end, we have 65% of these 10,000 who are frail. This database was a database of end-of-life people, so it's secondary data. All the other provinces will have new data. So it's a bit special in Nova Scotia. And so you see that some codes are not used at all in Nova Scotia. Incontinence, falls, nutrition issues. So we're going to be interested in looking if the provinces are all using the codes in the same way. Maybe some provinces use some of the codes. So you see that general health status indicators are very good for working with admin data. So we got 68% of people from that. So we also had problems identifying people, frail seniors, to conduct interviews. So The interviews are to be done with 20 patients or caregivers, 20 healthcare professionals, 20 decision makers from 5 provinces, from various settings of care. And the objective in general, so we have 3 specific, but to explore their views of healthcare services, resource utilization, and outcomes for frail seniors. So in Alberta and BC, we use posters that we placed in geriatric clinics. In Quebec, we asked participating clinicians permission to, so we asked them if they could ask permission for the frail seniors that they were in charge of, that we contact them to invite them. So we weren't able to recruit anybody in Alberta. Only a few patients were recruited in BC, but it's still going on. And in Quebec, a few patients so far. So I think the strategy in Quebec is good. Maybe sometimes a care provider want to protect their senior patients, and that's one of the reasons why they wouldn't want. So, oh, this person could be good, but you know, he has health issues around this time of the year, or you know. So there's always something that's making it difficult. So. We still have to recruit patients in Ontario and Nova Scotia, and potential solution is to recruit in targeted settings. So in long-term care setting, that's for sure, we have frail seniors, and it's easier. Avoid the use of the word frail. So some people call it the F word in the team. I find this funny. Sorry, John. This is an example of our poster in Ontario. So we work with an ethical person from the Ethic Review Board, and he helped us frame this. And I like it because I think it really represents what a frail senior is, but it's not a short word. So it's senior who experience loss of energy, physical ability, cognition, or health. So this is what we're using at the moment. So let's look now at clinical quality indicators of frail senior care. So in the interview, at the beginning of the interview, we're asking our stakeholders to prioritize clinical quality indicators. So we present them with a list of 36. And we're asking them, is this a good measure of clinical care quality for frail seniors? And their answer, you see, strongly agree to strongly disagree. So yeah, we have preliminary results here. So this is only results from 25 participants in Alberta, BC, and Quebec. So you see that you have the best indicators according to them. So quality of life seems to stand out as a very important quality of care indicator. So in the second place, you have 2, reduction of symptoms, increase in provider competency or skills. And in the third place, all of these 3 have the same rating. So reduction of caregiver burden, increase in family physician continuity of care, increase in patient satisfaction with care, and reduction of the rate of emergency department visit. So Amin Choukou is presenting a poster on this work if you're interested. His poster is very near the entrance, and he's doing a correspondence. We also asked people why they rated this as important and why they didn't. So we have some insight on why people selected some. And he's also presenting the worst indicators. And so if you want to go talk with him, I'm sure he'd like that. So now let's look, and we're going to look at the results in the review. And because we have so much results, I decided to focus on those indicators that the people, the stakeholders, rated as the most important. So this is how I think we can really incorporate citizen or patient into the research. By only looking at the results, like they say, this is important to me, quality of care is important. So we had 36 indicators, but we're just going to look at those that are important to them. So here you have, in the review, we included 20 studies on the impact of an intervention. So you have here the results of quality of life, symptoms, and provider competency or skill. So you see quality of life, we observed an improvement in 3 studies. One was a 12-week small group physical exercise program. The other one was a multifactorial interdisciplinary team approach to fall prevention. And the third one was mobility intervention in long-term care facility. And for provider competency or skill, it was improved in the VITA study in interdisciplinary, multifaceted knowledge translation intervention in long-term care. The other indicators here, so you have caregiver burden, which wasn't improved. So I only listed the ones that were improved, just focus on those ones. So you see patient satisfaction with care was improved in the PRISMA study, a coordination type integrated service delivery model, alternate housing model, another study, and emergency mobile nursing service was improving in the rate of emergency department visit. We also had a mandate by TVN to look at the differences in the different characteristics of seniors, how these would impact quality of care indicators. Okay? So if I look at the indicators that are most important to people, we didn't find any studies looking, for example, at quality of life, whether people with higher cognitive, more important cognitive impairment would have different quality of care. So it's more like cohort type of studies, right? So only for rate of emergency department visit did we find studies. So you see here, so this is a bit complex table to present, so bear with me. So you see the reduction in the rate of emergency department visit is influenced by, so you can decrease the rate of emergency department visit with continuity, according to the Ref ID 317. But then this indicator is worsened if you're a man, if you have cognitive impairment, if you're using the hospital or long-term care. So we're going to have this type of results for a lot of indicators and a lot of covariates. So administrative data now. So we did do another exercise of prioritization with other people. So we started off with the indicators studied in Nova Scotia and reported in the review, 45. Then we selected 13 among those that were really important, really relevant for frail senior care. And we selected 6 using a Delphi strategy, a survey with the researchers in the team. So these are the 6 that were selected in the survey. And in yellow, though, it's the same ones that were selected by stakeholders. So you see that the perspective of stakeholders versus researchers is a bit different. But there is some coherence. Okay, so the number of hospital days in the last year of life was ranked the best, and the rate of emergency department visit in the last year of life was rated as second. So if we check, now we still only have the results from Nova Scotia. If you look at the emergency department visit and number of hospital days that we have extracted from our new cohort in Nova Scotia, you see here the results for the last year of life, the last 30 days of life. So you see the emergency department visit, we have a median number of 2 emergency department visits, a median number of 19 hospital days. So of course, we don't have the perspective in all Canada. We're still working on this, but it's giving you a taste of what kind of results we're going to get. We're also going to look at the association between frail senior characteristics and indicators. So you have the characteristics on the left side, sex, age, community size, income. So we couldn't extract others from the databases we had. So this is what we're going to be able to look at. And so you see for these 2 indicators what we have. So in red you have when the association is significant. So for example, if I take the first one, being a female is predictive of less emergency department visit, but it's predictive of more hospital days. Okay? Age, being younger is predictive of more emergency department visit and of more hospital days. And for community size, so living in a bigger city means that you're going to use more these services, emergency and hospital days. And so income quintile doesn't seem to be strongly associated. Only in the lower income do you see increased number of hospital days. So this is the kind of results we're going to get, and I'm really excited about this to be able to share with everyone. So it's part of our mandate also to share the data with other researchers because it's going to be really a baseline. So I think I don't have a conclusion. I forgot to add a conclusion. So, but my conclusions would be that it's really a baseline picture, and if anybody wants to work on this and pursue the work, I'd be glad to share whatever we have. Thank you.